It's nice to have an international conference. It's a pity that it's in Cape Town. But it's about the alienation of the context in which we work. And part of what I would like to be talking about, and part of what I've written about, is about alienation and the struggle against alienation. I would like to make a special welcome to Comrade Samu and Comrade Numsa, who might, I hope, be sitting here. It's a very sad thing when workers build unions and they find the politics of the bosses taking over those unions. And workers have to struggle to take what they have built themselves back into their own hands. And Numsa has positioned itself in that struggle. Samu is a little bit in the shadow, slightly there. Hopefully it will be there fully. But that is a struggle which is going on. It's also a very, very sad thing when people have to struggle to give care. Care is a basic social necessity. I actually have very few things to say. It'll take me long to say it, but I have few things to say. Care is a basic social necessity. We can't argue about it. It just is. There's no one here who hasn't received care. There's no one here who hasn't needed care. So there's no debate. I also think that there's no debate that the front line of the health service, the ordinary experience of everyday life for millions of ordinary people in South Africa and internationally, is the community healthcare worker. There are health professionals. The situation of the community healthcare worker is dubious. Health professional, sort of, but not quite. Employed, more or less, but also volunteer, sometimes unemployed. And yet in the experience of people needing care, needing access to the public health system, it's that community healthcare worker who is the real interface on a daily basis. And yet they have to struggle to give care. It's sort of sick. It's kind of, I heard in the other seminar people talking about things which are disgusting, things which they're ashamed about. It's disgusting. It's completely shameful that the delivery of an essential service means that the person who's trying to give it has to struggle and ends up being sick from the very struggle of trying to give that care. I've said everything I have to say, but I'll continue. The title of the paper is Caregivers and the Struggle for Care as Essential Public Service. Care is an essential public service. There's a struggle to give care, but someone has to do it. And that someone who has to do it is the caregiver. I'm purposely blurring, not just because I'm not a health professional and just a sociologist and we're very vague about everything. I'm purposely blurring what I mean by community healthcare worker for two reasons. The first is that people who are community healthcare workers have designated themselves as community healthcare workers. They can, in the structure of the public health service, be given different titles. But collectively in organization, they have decided to call themselves community healthcare workers. The second reason that I'm blurring it is that if I put 4 women in front of you, and one was a nurse, and one was a community healthcare worker, and one was a domestic worker, and one was an unemployed woman, and you looked at them, you wouldn't be able to tell which one was which. And if they told you the story of their everyday work, you might still not be able to tell which one is which, because they very often are doing exactly the same work. So the community healthcare workers I'm talking about include all of that. They include the millions of unemployed women who are essential to the provision of care in this capitalist society, which dumps that responsibility onto them. So it's about struggle at the barricades of everyday life. There's sometimes not drama, there's sometimes not organization, they're sometimes not recognized, they're sometimes not seen, but they're there. And if they were not there, many, many people who need care would not be getting it. And there would be people who are sick when they could be healthy. And there would be people who are dying when they could be alive, because they are not receiving that care. And maybe that care is coming from somebody that we say is unemployed. Maybe that care is coming from somebody that we say is a community healthcare worker. Maybe that community healthcare worker is employed by the government on Monday and by an NGO on Tuesday and unemployed on Wednesday. I'm slightly over-dramatizing it, but it's not over-dramatizing it. It's completely accurate. It's what happens. I'm trying to turn our eyes also to the issue of compassionate care. We work in a context in which we know that healthcare is commodified. To me, that's the starting point. You get what you can pay for. I again don't think that we need to debate that. I think that's a point of departure for us sitting here. But compassion is a very difficult thing to commodify. It's quite nice because it's there all the time, but they still haven't found out how to make a profit out of compassion. The capitalists, they can make a profit out of people simulating compassion. They can make a profit out of air hostesses having to smile at you the whole time. They can make a profit out of the carefully trained workers in this hotel who've been taught, and you can see it, man, who've been taught to approach you with concern and a smile. You don't know what's going on in their hearts. Maybe in their hearts, in their souls, they're thinking about their children, not you. But they have to simulate compassion. But the real emotion, the real disposition of compassion, you can't just buy that. You can't just fabricate it. It's not like a table or a microphone or a computer. And yet, those of us who look for vision, those of us who look towards a socialist future, there's going to be no socialism without compassion. That compassion of person to person is collectivized as solidarity between groups of people with each other. And the socialist future that we're trying to build rests on that. And the most exciting thing for me as I try and do this work is that the resource is there. There are millions of people who are already doing it. I'll come to the dreaming about them in a second. We have a restructuring of some kinds of the healthcare system in South Africa going on at the moment. There's not me, hey? I lose sense of time. He's got a thing there saying 1 minute, which I think is offensive. We have a restructuring going on, and we don't need to pretend that we don't know where that restructuring is heading. I think we know exactly where it's heading. It's heading to the formalization and incorporation of the community healthcare worker into a more tightly regulated system at the bottom. That's where we're heading. If things stay as they are, that's where we go. The community healthcare worker is already at the bottom. She doesn't need to be brought in at the bottom. She's already placed at the bottom. She already has everything dumped upon her at the bottom. But I fear with a deep desperation, because we've been there and we've seen it in other places, that we're heading for a replication of precisely what has happened with domestic workers here. For years and years and years, domestic workers struggled to be incorporated into the system, to be recognized, to be part of regulation. And then the law came, and that was their success. And that success was hard won. There were people struggling for that success. It wasn't a present from anyone. They won that. And then what happened with that? The regulation took exactly what was happening to domestic workers and it put it into law. And by that stroke, what had been illegitimate and unacceptable and intolerable under apartheid became legitimate and acceptable and tolerable in democracy because they now had their law. And when domestic workers are struggling to actually change what is happening to them every day, they repeatedly hear, but you got your law now. You got your rights now. Yeah, be satisfied. There are other people who haven't got that. You're lucky. In such and such a place, they haven't got it. I don't think we need to pretend that is where we're headed. And we will go there unless we is right. There's a question, of course, who we is in that situation. I would love community healthcare workers, in a certain sense I would like them to be here to talk to you about it. I don't claim to have done research. I claim to have done some work with community healthcare workers. And I claim to have listened to them. And I claim to have written down some things as I'm listening to them. And I've taken back those things I've written down, and they have discussed it. Because they want to carry their story outwards. They can also sit in a room like this. They want to carry that story outwards. They want to make a connection to others who share that same lived experience. So I want to read you a bit of a story. I don't know how it's going to go with time. Nomsa is a community healthcare worker. She started with that work long before she got a job. There were people who were sick around her. She looked after them. When there was no one to wash them, she washed them. When there was no one to cook for them, she brought them food. When there was no one for them to talk to, she sat with them and listened. When they had no money, she helped them to fill in the forms to apply for a grant. Sometimes she left them with a few rands, even when her own pockets were empty. She started to see when people had TB, and she learned where they should go for treatment. She went on some courses, which repeated the knowledge she had already. Later, she found employment as a community healthcare worker. She started to get some payment for the work she was already doing. First, the payment came from the government. Then it changed and came from the NGO. But the work did not change. Then the NGO said there's no money, and they cut her pay in half. But the work did not get cut in half. There were more people to care for, more people who needed her. With her money cut in half, the work got harder. Sometimes she had no money for transport, so she had to walk, no matter the weather, no matter whether it was dangerous. I'm jumping. Inside herself, Nomsa knew that others needed her. She knew that she was doing important work. She was proud, but she carried the needs of other people on her back because no one else was caring for them. And when the government and the NGO treated her like this, she started to wonder. When she saw the same problems day after day, even with all her work, she started to wonder. When she wanted to help, but could not do everything, she started to wonder. Nomsa was giving care all the time, but she felt sore, because the care was never enough. There was no care coming from other places. She worried all the time. She was doing useful, caring work, but it was making her sick. In a way, that's my findings. The findings have been validated by groups of community healthcare workers sitting and saying, that's us. We are Nomsa. That's our story. That's right. You got it. Tell them. Tell them what's happening. So can we do anything about it? Well, who's we? We are researchers. We need research, but research is not going to change us. We're academics. I'm an academic. We need academics, but academics are not going to change us. There's a resource which is going to change it. That resource is too invisible to us sometimes. That resource is the millions of women who are doing it already. In a context of deep commodification, where the public healthcare system is sometimes a transmission belt of public money into private profits. That's what public healthcare sometimes do. Where commodification is rampant within the public healthcare system, where the ethic of commodification is there, where the practice of commodification is there. There are still millions of people giving care outside that commodification, despite that commodification, against that commodification. They can change it. We can decide to support them. We can decide to respect them. We can decide to listen to them. We can decide to research them. We can decide to lecture about them. We can also tell them, well, it's impossible. You have to be realistic. That's dreaming. They come, these lefties, and talk about socialism. That's interesting for them. But that's just a dream. Sick people who could be healthy. We have the knowledge. People who die when they could be kept alive. We have the knowledge. People who need care. We have the people who give in care. They just face a struggle, man. There's just things placed in the way the whole time. And eventually the context of commodification, the context of the rules of this world, which say that you get what you can pay for, and you don't get it otherwise. That's in a way. That's why this is a struggle. It's a struggle for healthcare. And it's not going to be won if those same things are there in the way. And it's not going to be won if we huck about private-public partnerships, which is bringing the disease of commodification deeper into the public healthcare system. So it's just going to have to be made possible. Now that's a dream. Well, it's also a dream that an unemployed, untrained, unrecognized, disrespected, denigrated woman is out there now giving compassionate care, which is better and richer and more useful than the most advanced care in the private healthcare system. That's a reality. So just imagine if there's a problem with dreaming. Just imagine if that resource was respected. Just imagine if we listened. Just imagine if we restructured on the basis of that resource being at the core and the heart of a different vision. Just imagine if that resource was resourced and organized and it was all planned. If it's a dream, let's just make it true. Let's just make impossible things possible. Otherwise, we're going to sit with the same problems. So let's dream. Thank you.